I now invite the Prince Charming of MOS, Dr. Vardhaman Kankriya, to give an introduction to his mentor, the illustrious Ioannis Pallikaris sir. Vardhaman, over to you.
Thank you so much. It is immense pride, gratitude with which we actually welcome my mentor and the chief guest of today's function, Professor Ioannis Pallikaris. We call him the engine of innovation with the human face. So basically, Professor Pallikaris is a life spent on innovation and on transmission of knowledge for generation of ophthalmologists around the world. He's a historic figure in the world of in ophthalmology itself, and he's considered as the father of modern refractive surgery, thanks to his enormous and pioneering contribution to technological advancements, especially in the development of LASIK, epi-LASIK, and ray tracing technology. Many wouldn't know that Professor Pallikaris was actually trained first as a vitreoretina surgeon and then found his love into refractive surgery later on. Professor Pallikaris' research interest expands in all fields of ophthalmology, including refractive surgery, visual optics, medical lasers, biopolymers, retinal surgery, and image analysis. But most importantly, in design and development of microsurgical instruments and surgeries. His most significant impact in refractive surgery and the most famous contribution in ophthalmology is in the form of LASIK. He performed and studied LASIK for the first time in 1989, and following year, he performed the first LASIK on a patient in University of Crete. Since then, he had a great impact in the field of ophthalmology, while he is considered as the father of LASIK, the most worldwide acknowledged and used surgical technique in correcting refractive errors at present. For patients, LASIK became synonymous with refractive surgery, similar to Xerox is to photocopy. Another significant invention of Professor Pallikaris is ray tracing technology. And of course, we all know that Professor Pallikaris has developed a lot of other tools, including rotating brush for PRK procedures and the innovation of epi-LASIK itself for thin corneas. Professor Pallikaris also has a lot of contribution outside of optics and refractive surgery in study of ocular rigidity, hydrodynamics, and its association with diseases such as glaucoma. He has published more than 200 articles in international journals, but most importantly, most of these articles are having very, very high impact in changing the way we practice ophthalmology today. He holds more than 20 patents related to optics and ophthalmology. Professor Pallikaris has been awarded more than 15 very, very prestigious international awards for his groundbreaking contribution to refractive surgery, most notably the Barraquer Award from American Academy of Ophthalmology, the Charles Kellman Innovators Award from the American Society of Cataract and Refractive Surgery, the Bancroft Medal, which is the highest medal from the European Society of Cataract and Refractive Surgery, and he has been also the president of the prestigious ECRS in the past. Along with his amazing innovations, he also is humanitarian. Professor Pallikaris and his team has served in the isolated areas. He has served in the isolated areas. One second. He has served in the isolated areas, which is called as a University of Mountains, with his wonderful wife, Mrs. Varvara Terzaki Pallikaris, and founded University of Mountains, a not-for-profit organization to provide eye care to the people of villages and mountains who do not have access to the healthcare. He is a global mentor. Professor Pallikaris has been strongly supported and provided mentorship for fellows around the world. Many of Professor's fellows have contributed significantly to the scientific community at a global stage. Professor Pallikaris has been a mentor and a father figure for me personally. He has guided, supported, and mentored me in my professional and personal life since 2011. When I joined Professor as a fellow, this was in 2011, he actually treated me like his family. He introduced me to the Greek culture. He invited me to stay with him and his family for a week's time to celebrate the Greek Easter in a small, beautiful village of Iomannas. That Easter is a lifetime memory for me, and he has a memory for me. He has deep love for India and Indian culture, especially as Greece and India share the common thread of ancient cultures. So Professor Pallikaris has gone out of his ways to support his fellows, and one such instance has been that last time when he actually came to India to inaugurate our eye hospital, and we also named our refractive surgery center and department after him as a respect. He actually made a lot of arrangements to change his schedules and actually came for the same. He personifies a mentor who is a friend, a guide, a guru, a father, and a best critic. Professor says to all of us fellows, I don't want to create fellows. I want to create future mentors for the future fellows and innovators for the future patients. Thank you very much. Here to Professor Pallikaris. Thank you.
Now I invite Professor Pallikaris for his inaugural address. His topic is Journey of Innovation in Ophthalmology.
Good morning or good afternoon. Probably we have some different on the time here. Do you hear me first of all?
Yes, yes, Professor.
Yes,
Right.
yes, we can hear you.
Dear President of All India Society, dear President of Maharashtra Society, dear colleagues, friends, it is a big pleasure for me to join you. And of course, it's a big honor also to be among you. Because what Vardaman said before was not absolute right. That's been that when Vardaman came here in Crete, in our university, I believe that he was much more influential to our life than what we have done to his profession. And today, India, for me and for my family and many from my doctors here, is like the second country. And you have to be very proud about Vardaman because after he came back in India, many Greek doctors, they came to his hospital to be trained. So I believe this is really very important what Vardaman succeeded. And of course, he makes also me to feel very proud about him and about my, let's say, target to help some new doctors to become mentors later on. So now I will try to share my screen in order to present from here my presentation. Do you see my screen?
Yes, Professor. Yes, Professor.
All right. Besides the fact that Vardaman has already explained everything from my screen, let me go here. You see this is a full screen or also part of my screen?
Right now it is a part of your screen, Professor. You have to go to the, yeah. You may have to just click on the.
All right, now this is a full screen and I can.
Slideshow, yes.
Here. All right.
Perfect, thank you.
I have a full screen. So regarding my journey of innovation, ophthalmology, I think Vardaman said already everything that's happened in my life during my profession. But I would like to tell you that I don't want to be a doctor. My choice was to be an architect. So that's by default, I came in the medical school. So when I was starting my career in ophthalmology as a resident, it was in Zurich, 1977. And as you can see here in this sketch, which has been done from one from my colleagues at that period in Zurich, my first investment was to make a windsurfing for surfing in Zurich Sea, of course. And in this drawing, you see by side also a few, let's say, instruments I was designed in that period when I was resident in Zurich. So you recognize here probably a placido disc and trephination here and some other small instruments. So for that period, I wanted really to do some research, let's say, and do some innovative things. When I went to refractive surgery timeline, you see here many people on the screen. Somewhere you see myself also around 1990 was a period I developed LASIK. But for me, the most important persons in these slides are, of course, Baraker and Fyodorov. I think those people, they have the major, let's say, merit in modern refractive surgery. The before LASIK period, I was working with some new ideas also. And this is my thesis when I was in Zurich. And this is the publication of that period on the preoperative Placido photography in keratoconus and its meanings in conjunction with postoperative astigmatism. I published in Graphics Archive here. What I have done actually, I took Placido photographies that period, and I was using a very primitive computer to measure, let's say, the dimensions of the several axes in topography in order to find a way to identify, let's say, the structure of the cornea. It was, let's say, the very first kind of topography, let's say, that period. What I could make it in this study, I could predict the shape of the opening of the cornea, of the recipient cornea, when we have done, of course, a round trephination because of the strength of the cornea and based on the Placido here photographies, I could identify sorry, come back here. Let's say the shape of the opening and of course then the strength of the transplant in the opening. At the same time, I was designing a trephine which is very similar to the Baron trephine. You see here on the top left, it was a 3-edged trephine with a section, which actually the same concept like the Baron trephine. After that, it was the period of the RK, which became very popular, and I wanted to make a diamond knife which can make more precise and more safe, let's say, cuts, and also to deepen the cut from the center to the periphery, because we knew that when you go 90% of the thickness of the cornea, you generate the highest effect on the cornea. So this is my pivot knife, which was the knife which was really very impressive how easy and how safe you can do a very precise, let's say, incision in the cornea at that period. Also, the relaxing incision, for the arc relaxing incision was also very popular that period, of course, doing with a diamond knife before the laser era. And I designed this architome from downward at Kent. So I could use this architome to make very precise incision in the length, in the arc, and in the depth. So I could customize, let's say, any incision using this precision instrument. And on the left, you see from our publication that we developed a kind of nomogram, and we could identify how many cuts, how long, and how big and how deep has to be done in order to have the best outcomes. PRK started at that period, and of course, last area we have already some first experiments with X-ray laser for 1960s already. Troquel has done the first corneal excision, and L'Espérance and McDonald the first PRK. The FDA came much later. At that period, but the first problem was how we remove the epithelium. So I designed this brush, which is, I was using actually a scrub from our hands in the surgery, and then I cut it around it from this scrub, you see that, apart, and then I rotate it, and then I could make several brushes that you can see here to remove the epithelium. I get also a patent for the United States. It was much before the MOS brush comes in the market. PRK becomes not very popular, of course, because of pain management, slow visual recovery, and corneal haste and regression. So then we have to overcome this problem. So I came to the idea to ablate not on the surface, but deep in the stroma. So I have designed my first microkeratome you see on the top left here, with a very primitive keratome just for the rabbit experiments and the healing studies. And then I have my very first keratome for the human, which is down below, which is an oval opening, and the publication on that period. This is a video of the very first cornea cut in the human eye with a microkeratome in order to make a flap. This keratome has been manufactured from Polytech. I have designed the ring. You can see here, I have some holes on the side and a small plaque also. So the plaque is used to identify how far the oscillation head of the keratome has to go farther. So somehow this was a way, let's say, to predict the size of the flap. The first flap, of course, was not as thin as today. You realize that the very first flap was very thick and very rigid. This first flap was, I think, about 300 microns. So you see that the flaps come immediately back. And of course, the hinge is very wide, and the size of the flap also is quite small. But it was just enough to make the laser ablation, as you will see on the next slide with the very first excimer here. You see the border of the ablation in the flap. Now, LASIK in the beginning has no limits. We started to make high corrections with small optical zones. We don't have any idea what's happening in the future with several optical phenomena and also with the biodynamics of the cornea. So the first we faced was the halos in very small ablation zones, but quite stable results. You see here 11 years after LASIK, very steady outcome. But at the same time, we start to rethink about the quality of the cuts and what was the effect of the flap on the biomechanics of the cornea. So we discovered, of course, with new technologies, the high order and the low order aberration, and we could have a much more precise, let's say, view on the optics on these corneas. And of course, Ectasia was started also at that period, and then we have a better understanding about the biodynamics and how important it is to make a very thin flap and preserve a certain thickness of the cornea. So that's why when you see this timeline here, we start from PRK. Because of the PRK problem, we come to LASIK. And then because of the LASIK problem, was the risk of cornea ectasia and the applicable flap-induced aberration, we started again to think about the advanced surface ablation, to go to the surface. So at that period, I also developed epi-LASIK in order to have a certain indication, like thin corneas, flap-related complications, flap-induced aberrations, preoperative dry eye, which was a major problem later on, and some dystrophies. So the epi-LASIK has an idea, instead to cut the cornea to separate the epithelium from the surface of the cornea. So we could make it separate the epithelium very safely under the basic membrane, if you can see here. So we don't destroy any epithelial cell with this separator. And of course, this became very popular. You see here all the companies, they've done, let's say, microkeratomes redesigned somehow for the use for epi-LASIK. The problem was that the first day, the result was amazing, very clear like LASIK. But the third to fourth day, the cells, they start to die. So I mean the flap cells, and new cells, they start to generate from the cornea. So this 3-4 days period, we have a loss of line of vision. Of course, has been recovered, but the results was not the optimal one. And 94, 95, we start to think also about the quality of the vision and how evaluate, let's say, the total optical system. So I have a friend in Kiev, Vasil Molebny. So I asked him to make for me a tracing system to trace, let's say, line by line, all the refraction in the eye. So we developed the ray tracing technology. Today is very popular, and in India, there are many units I know, and you can make many things with this machine. It's amazing. I mean, you can predict toric rotations. We can, let's say, re-estimate the rotation or the false rotation of the toric lens, and he guide you how you should re-rotate or reposition the lens in order to have the best results. And lately, we have developed this lens dysfunctional index, which actually, in this case, this is a 475 here. That means we have a total refraction here on the right. We have a blur image, as you can see, so we can find out what part of this blurring effect is come from the cornea and what come from inside of the eye. So the cornea here, topography show us a very clear image projection. So everything comes from inside because of the lens, of course, and you have here some distortion of the quality of the lens. So this is a pre-cataract, let's say, stage where we can understand better the patient concerns, because many patients, they come, they have a kind of difficulties to read. They are not very happy with the lighting. They still have 20/20, but the cataract has started. So this tool can give us more information on that. In our days, of course, we came after the LASIK period with the use of the femtosecond in our life. And you see that after 2006, femtosecond came in our life, and SMILE today is very, very popular. all these here platforms you can see here, they can be used in several ways to optimize any kind of refractive correction. I don't like to stay longer here, but I would say that any platform has some certain, let's say, super achievement. Some platforms that don't do it very well. I don't go deeper on that, but the ones that experience, they understand what I mean. Now, of course, the next ultimate goal is to have a corneal surface which is absolute, let's say, corrected with any irregularity. We know that the best way to correct any corneal irregularity is the use of the hard contact lenses. So if we put a contact lens on the eye, we achieve the best corrected vision I could. This is a perfect optical system because the contact lens, the hard contact lens has an absolute spheric surface. I came to this idea, by the way, much earlier, in around 2000, around 1990 to 2000, and I developed this palm technique. The idea is to reproduce, let's say, on the corneal surface, the same quality of the optics from the contact lens. So I use a contact lens, I put under the contact lens a thermo-reversible material, and I molded a new surface on the cornea. So I removed the contact lens then, and then I was ablating with a PTK. Here you see on the right side how nicely I could correct all this irregularity on the left. So it was a very impressive, let's say, technique, and we started to use to make training around the world. But we failed because actually during the ablation rate, we have some, let's say, side biomechanical effect, and was not very precise the result. Now, if we're going to SMILE today, I can raise the same question. Is any intracorneal lentil which can correct 100% the surface irregularity? Theoretically, yes, by customized ablation and intrastromal profiles. But you know very well that practically it's almost impossible because of the technology limitations. Even topo-guided X-ray laser today, they cannot do it. Now, is a way to reproduce the same surface irregularity in an intrastromal cut and generate a custom lentil which include all these irregularities in one surface, and on the other, the total spherical refractive error. This is, let's say, the ultimate wish and goal, of course. I developed a new technology which can fulfill this need today. So the idea behind is, again, I use a gel, but this gel, of course, is a different one than the previous with the palm, because this gel has not to be ablated. It has to be used just to fill the irregularities of the cornea. That means it has the same optical parameters with the cornea. So you see the concept here with the gel. I put a cone on the top of the cornea, and then I will use UV light, and the gel solidified. That means I have a new, actually, super cornea surface. Then I make my first cut with this complex. So the first intrastromal cut is parallel to the new cornea surface, actually, with the gel. But intrastromally, this is mimics the irregularity of the top of the cornea. Then I remove the gel, and I put again a second cone without gel, and this time I do a parallel cut from the surface of the real cornea. So what I have done, I generate an intrastromal lentil, which includes all the surface irregularities. When I remove it, I have a super regular surface. Now, what I like to show you here is a very impressive video. You will see how this gel solidified and how it works. This is the head of a normal femto laser machine, by the way. This is, I think, from Alcon or Wavelight. If you are a user for that, you recognize this, the cone. I just change the shape on the top of this cone, and this became curved. It's not flat. Now I put the gel. It's a very simple process. Then you can put on the top this cone or any other cone, by the way. That can be used by any machine. You irradiate by 1 minute. It's a very fast process, of course, that the gel becomes hard. Then you see the gel is quite sticky. That means the eye somehow is fixed, all right? It's not moving. Now, just to demonstrate to you, I try to flip up the cone. very carefully. So the cone is very clear, you know, the surface is very clear here. And here, just I have a new cornea, let's say, absolute spherical surface. Now, just I try to remove this material just to see how nice looks this, let's say, interface. The new cornea interface is like a custom contact lens, by the way. So I think you understand the concept here. And what I have done also, I was trying to prove that the cut through the material is the same quality. And you see, this is the cut intrastromal without the gel, with the femtolaser. On the right is with the gel. And you see the right cut is even better than the left one. So this is the concept of this procedure. The next toy that I'm currently working on also is how we can bypass the problem with the PCO formation, the misalignment of the lenses. And you know, all of you, that the premium lenses today, they are needed a very precise, let's say, positioning in the eye. The effective lens position is very important in this type of lenses, of course. And of course, PCO is no doubt that could be also a problem, and also tilts. And in particular, if we like to exchange for some reason unless we need to have a safe, let's say, capsule environment to do that. And in pediatric ophthalmology, this is very important because we know that we have to change the lens at least 2 times, let's say, and we have much higher fibrosis. I developed this ring which somehow expands the peripheral part of the capsule. What I do, I will reconstruct, let's say, the shape of the capsule. I don't leave the capsule to collapse. Okay, this is not a new idea, but this particular ring we have designed have several, let's say, features that are unique, because this is one size fits all, can fit to any capsule size. This has a certain tricks how you stabilize the optic of the IOL in the center of the ring. There are some specific clips to do that, for example, and spacing also is very important, and material is very important. So here you see an eye immediately after the surgery, where you see the very clear, of course, optic of the lens, very nice center, and on the side, you can see here the 2 special clips that are used to clip the optic inside. So you ensure, let's say, the lens position, the effective lens position, which is very important for the calculation of the IOL, and also you don't have any PCO. And this is a case after long period. You see the upper picture is for one eye, and the other is the other eye for the same patient. The first one is with the ring, and the other without the ring. So the second eye start already to have PCO by 8 months. The same is here, which is 6 months after the surgery. The same patient left with the ring, right without the ring. You see on the right already PCO started. And here is the most important, I think, slides, because here I demonstrate to you how nicely the optic of the IOL is placed just in the center of the anatomy of the previous, let's say, normal human lens. You see the anterior capsule, the capsulotomy is upward from the optic here, and you see also a great distance between the optic of the IOL and the posterior capsule, which is, as I said, is absolute clear in this case. Okay, come back to Zurich, and I'm finished. I like to say that in Zurich, beside the first sketch, I have another sketch, this one, because I break my hand by skiing, and then I was using the gips, and I went to the clinic to serve the patient. So the guy who made this sketch said that Pallikaris can use the break hand to measure the intraocular pressure, or probably the rigidity of the eye. Of course, at that period, 50 years back, I never thought about my rigidity project. But the beginning of 20s, 2090 to, let's say, no, 2000, close to 2000, the beginning of the century, I started to think about how important is the dynamics of the eye, and particularly the hydrodynamics. So I introduced hydrodynamics as a concept, because all of you understand that when the blood flows inside the eye, in the choroid, take a space inside the eye. So this space, let's say, has to expand the eye somewhere. So one place which is expanded is the cornea, and we see it when we do, of course, the IOP measurement with the Goldman tonometer. Also, what's happened at the same time, the flow here is much faster, so from the aqueous of the arterial chamber. If the eye is myopic and is the sclera is thin, we can see also that the whole globe will be expanded. But I think the most important place is here in the optic head, because here, because of the lamella cribosa, you know that when the internal pressure is increasing, the blood flow is blocked somewhere here. And it's very important really to understand all these dynamics. I developed this complex system, as looks like. This is a micro pump, but it's very simple to use, because what I do actually, I use a very small needle and I put this inside the eye before any cataract surgery. And the system just pressurizes very small micro amount of water in the eye and then follow up the internal change of the pressure and everything related to the blood flow. And of course, we have done this to be non-invasive. And in this instrument, I have much more information because I compare at the same time the heart rate, as you see, the intraocular pressure and the blood flow and the rigidity, and there are a lot of information that can lead us, let's say, to a better understanding of this hydrodynamics. This comes all this in this book, which by the way comes next month out and published. So I would like to thank you for your time and your patience, and I hope that I don't take so much time, and I hope I will be soon in India to see my friends. Thank you.
Mute. Vardhaman, Dr. Vardhaman, you're on mute.
Hello. Yeah,
Yes.
thank you so much, Professor. I think this was once in a lifetime opportunity for many ophthalmologists here in India. And we are so thankful for all your innovations, which have changed the lives of millions of patients around the world. And of course, all the ophthalmologists. Thank you very much for your time that you have spent with us and all your generosity. Thank you for Maharashtra Ophthalmological Society.
Thank you very much. Have a good day.
Thank you, sir. Gratitude is the most exquisite form of courtesy. Now I invite Dr. Sirish Thorat, sir, our new secretary, to give vote of thanks. And before that, from our MOC side, that means me, Dr. Neha Deshpande, and Dr. Vaishali Une, madam, we are signing off from this wonderful virtual inauguration of the conference. Thank you.
Good evening, all. On behalf of organizing committee of MOS, I really thank Father of Modern Refractive Surgery, Professor Pallikaris, sir, for sparing his valuable time for this function and delivering wonderful lecture. It is our great honor to have you as a guest of honor, sir.